Welcome to Variations 4, the cardiovascular unit. In this video, we'll cover questions 15 to 18, which is primarily concerned with atrial fibrillation. Let's start with 15, which is talking about the etiology, and we'll talk a little bit about the results and what this yields, what this leads to, atrial fibrillation. So we just look at a little picture here off of the web. What happens is you have some kind of event in the atria, some kind of ischemic event, basically yields the formation of what's called ectopic foci. That's E-C-T-O-P-I-C, new word F-O-C-I, ectopic foci. What those essentially are, they become like new pacemaker cells. So as you know, you usually have your SA node, which is your primary pacemaker. Now suddenly you have these rogue pacemaker cells in the atria, all thinking that they're going to control the rhythm. And what you end up with is a very fast and disorganized rhythm in the atria. Of course, this rhythm spreads to, has impact on eventually, how the ventricles are contracting and what rhythm they're going at. Of course it would, because it's all the electrical current passes through the whole heart. It starts up here, but it moves its way down into the ventricles. So of course the ventricles are affected. A very practical, before I get to that, the practical side of it, let's just look at an ECG here. Here's your regular ECG. You've got your P wave, your QRS wave, and your T wave. Very nice, very nice, curves here, nicely spaced out, very readable. Compare that with the atrial fibrillation ECG down here. A couple things to note. You've got your QRS waves happening at a much higher rate for the same time period. And it's really actually hard to even make out the P waves. There's so many of them and they're so jumbled. That's Afib. If you just think of the explanation I gave to it before of these atria moving at a much faster and disorganized rhythm, then of course, as we can see in the ECG, that affects the ventricles as well. Practical implications of this. So when you place your stethoscope, the diaphragm of your stethoscope on the apex of the heart, which is typically what we're landmarking for when we work in med surg. We're going for the apex. Afib, you'll typically get a rhythm of, in those circumstances, under those conditions, you'll typically get a rhythm somewhere between, 120 to 180, depending on what meds the patient's on and if they've even taken their meds. So somewhere in the hundreds, that's safe to say, you'll get in any case. What is it you're actually hearing? Are you hearing actual Afib, or are you hearing are you listening to the ventricles during that Afib? I guess, are you hearing the atria or the ventricles? Whose rhythm are you hearing? That's really my question. It's kind of an easy question. Of course, your stethoscope sitting at the apex of the heart, you're sitting there listening to the ventricles. That's the most common area that we auscultate in med surg is the ventricles. So that rhythm of about, let's just say 150, for example, is actually the ventricular rate. And it'll probably be an irregular rhythm. So it'll be running at an irregular rhythm and it'll be 150. And you'll think, whoa, that's a high rate and it's an irregular rhythm. No wonder he's got Afib. But guess what? The atria are actually running at a much faster rate. Somehow this electrical impulse, the effects of it get diluted as we move to the ventricles. But up here in the atria where it's all kind of started, these ectopic foci are, you can get those ventricles running, you can get those atria running at somewhere between 300 and 600 beats per minute. While at the very same time, the ventricles are running at around 150 or 180 a minute. Well, that's just an interesting point to note in and of itself. That's interesting, that the rate between the two are very different. The atria are much faster. Now that's interesting, just from the get-go. In a healthy heart, the rate between the two, as you can see in this ECG, for every P wave is a QRS T wave, without exception. Down here, you can't say the same thing. So they're running at different rhythms. And they're running inefficiently in and of themselves. The contractility is very inefficient, and the rate is very fast, and they're disorganized and not even running at the same rate, regardless of all that. So what's the big problem? If you add all that together, what's the big problem? Well, the big problem is that they're not in any state to fill properly, running like that. They're not going to have time to fill properly. And they're not in any state to eject blood efficiently either. Bottom line, your cardiac output will go down. Your cardiac efficiency will go down. The second problem that comes out of that is that you're going to have pooling of the blood in the chambers. And what's the problem with that? Of course, chances for clots. And you've got chances for strokes and PEs. All right, so question 15 really, question 16, our next question, asks us to look at the head-to-toe diagram on map 16. This is a very, very, very useful head-to-toe diagram to look at, just in terms of getting a sense of cardiovascular functioning in general. Although it is specific to AFib, it's really useful. If you can wrap your head around all the kind of what we're seeing in this map, for example, if you can provide rationales to everything you're seeing in this map, you're in pretty good shape for understanding the basics of cardiovascular functioning in the body overall. I'm not going to read through each point. I'll just hit some of the high points from which the other points follow. And that is that the cardiac output is decreased with AFib. And so all the CNS stuff we're seeing up here kind of makes sense because that's a perfusion issue. In terms of the risk for stroke, I've already talked about that in the last couple minutes. All these respiratory and cardiovascular symptomology near the middle seems to make sense, especially if you consider ineffective, low cardiac output affecting perfusion to organs such as the heart. Chest pain makes total sense. What we'll see in terms of the pulse, what we'll feel, makes sense in terms of what we've just discussed. So it's kind of like a CHF thing. You know, the whole AFib CHF thing really go hand in hand. You see them, these two conditions coming up together all the time. So just because cardiac output's down doesn't mean blood pressure's down. Why is that? Because if cardiac output's down, you've got an inefficient pump, an inefficient heart, then you've got blood backing up, in the lower extremities, blood backing up in the pulmonary areas. You've got congestive heart failure. And yes, it could be secondary to an ineffective heart, for example, a heart with atrial fibrillation. You don't always see CHF with AFib, but it's never a surprise when you do see them together. So BP could be up or down, really. Depends on the bigger picture of the patient. Yeah, and finally, just a little reminder on what lub-dub actually is. You might just want to review that. It's these valves closing. The ones that close right at the beginning of ventricular systole, or shall I say at the end of diastole, as soon as the ventricles have filled, those valves close between the ventricles and the atria. And then as soon as the ventricles have finished their systole, pushing blood out, dub, those valves closing on the pulmonary and aortic areas to prevent backflow of blood. That's really good to know, the lub dub. So there again, we see another example of how, you know, the average acute med general surgical nurse really is just picking up on ventricular action more than anything else. The lub dub we actually hear has more to do with the ventricles than anything else. Again, which is why when we're listening lub dub, and we hear this irregular rhythm and we say, I got AFib, we're actually counting the rate of the ventricles. All right, what's the next question asking us here? 17 is asking us to, we've kind of covered a lot of this. I'll just say right off the top, I'm not going to spend a lot of time on this because we talked about this fairly nicely when we talked about cardiac output. In fact, this question asks us to frame your explanation in terms of cardiac output. A video or two ago, we already talked about this. So let's take a look at it and see if there's anything new to add to the last video. But I'm not likely to repeat myself here. So again, we're seeing how the digoxin is affecting the contractility, which we did talk about, and the rate. And those are two components of cardiac output. Calcium channel blockers and beta blockers, as we discussed, affects the rate. Can also lower blood pressure too, of course, and that's afterload, but slows down the rate directly as well. We know what aspirin and warfarin are for, and you can read this yourself, but in a nutshell, we're giving these to decrease our chances of strokes or PEs, secondary to the pooling of blood in AFib. So what question does that bring us to? I believe that brings us to question 18. Unless we've already discussed it, map 17 at the bottom. Right, we did. Which meds affect the inefficient emptying? That again is the aspirin and the warfarin to prevent that coagulation, basically.